Hello everybody, I'm Namita Thapar, Executive Director of MCure Pharmaceuticals, and today we're going to talk about a very important topic, Parkinson's.
The first thing is we live in an age where there is a lot of information. Many patients have already Googled what they think they have.
My brother did not have it. My entire family does not have it. Why me?
I've heard it can be so debilitating that you lose your ability to speak.
Acceptance helps you to treat the illness much better.
Can happen in younger people and it can be associated with other symptoms that antecede.
I can understand anxiety and smell. Constipation, how is that?
So this is the new buzzword in the neuroscience of Parkinson's.
There should be no guilt in having fun.
We have two experts with us today. We have Dr. Joy Desai, a very reputed neurologist, and we have Dr. Harish Shetty, who's joining us for the second time for a podcast. And both these lovely gentlemen are going to share different insights and different aspects of this condition, so we learn more about it and know how to manage it better. So Dr. Joy, why don't we start with you? Let's start with the basics. What is Parkinson's in simple terms?
So people who have what is called Parkinson's disease by neurologists develop a range of symptoms. These are categorizable into simple subsets. So movements can become slow. One can develop a tremor, usually in the upper limb, that is in the hand, and it's usually unilateral. Balance can become suboptimal. So one has the feeling that when I'm walking, balance is not so good, and one can experience stiffness. So these four are the commonplace.
And is it usually when you're old, or it happens to younger people too?
It can happen in younger people less often, usually in older individuals after the age of 60.
Okay.
And it can be associated with other symptoms that antecede. The anteceding can be a long history of constipation, sometimes anxiety disorder, and I think that's a very big anteceding story. Change in the efficiency of sensing smell. So many a times we call that hyposmia.
Okay.
So all of these can be anteceding symptoms.
I can understand anxiety and smell. Constipation, how is that?
So this is the new buzzword in the neuroscience of Parkinson's.
Mm-hmm.
It's believed that in many individuals, the biological abnormality in Parkinson's disease begins in the gut.
Oh.
And it travels via the nerve that is called the vagus. The vagus is our wandering nerve. It's called vagus because it means wandering. Mm-hmm. And it travels via the vagus into the brain.
Right.
There is a school of thought now in science that believes that it can start in the gut with constipation, then lead to change in sleeping efficiency, sometimes talking in sleep called REM sleep behavior disorder. Mm-hmm. And then it leads to movement symptoms like shaking, slow movements, change in balance, stiffness, and change in handwriting. The handwriting becomes smaller. The individual goes to the bank and the banker says that your signature is no longer the same. Mm-hmm. These should all be wake-up signs that there's something which needs attention.
Let's say an aware patient, detects these early symptoms and goes to a specialist like you. How would you diagnose it?
So most important thing is the history. And following the history, there is a physical exam. On physical exam, there are corroborative signs. Mm-hmm. That means the neurologist is trained to examine and confirm that what the patient is narrating is translated into what can be objectively measured in the physical exam.
Right.
And often this is followed by imaging tests of the brain. Mm-hmm. So for a long time, the gold standard was doing an MRI. And now we have a little more advanced test for Parkinson's disease, which we do in some people. Not in everyone. It's called a fluorodopa PET scan.
Okay.
So essentially,
that's more definitive.
It's a little more definitive because the current thinking is that people who have Parkinson's or what is called Parkinson's disease experience these symptoms because their brain network in a very regional part of the brain stops making a neurotransmitter called dopamine efficiently. Mm-hmm. And this dopamine loss leads to these symptoms.
Right.
So there is a very strategic network in the brain called the striatonigral tract. It's in the small brain, in the midbrain, which goes to the deeper part of the brain called the diencephalon. These are all terms, but one need not be conversant with them. So the fluorodopa PET measures this network, the striatonigral network.
Understood.
And it is able to objectively show that when you give this FDOPA, the dopamine producing cells are not healthy and it shows as a part of the abnormality on the scan.
Understood.
So that can be used for confirmation. Sometimes when somebody has seen people like Dr. Shetty and are on medications which block dopamine receptors, and Dr.
So
Shetty,
medication can lead to
symptoms
Parkinson's
of
as well.
Parkinsonism.
For example?
Symptoms of Parkinsonism, slow movements, tremor.
No, what kind of
stiffness.
medications? Can you give me a couple of examples, Dr. Shetty?
I think antipsychotic medications, especially older ones, have to be given carefully. Even the newer ones, that can cause temporary Parkinsonism. Once the medications are changed, it comes back to normal. But very rarely, some patients whose Parkinsonism is initiated by the antipsychotic medication can continue for life.
So
when
that
there
is something we need to be aware of.
So sometimes when there is a doubt in the neurologist's mind that is this drug induced because the patient has taken medications, or is there an inherent change in the brain's generative degenerative balance, and therefore one could do an FDOPA test to confirm. If there is an FDOPA abnormality, then it is intrinsic.
Which is why a multi-specialty approach is always
absolutely.
needed. And that brings me to the next question. You've diagnosed, you've confirmed. How do you treat?
The first thing is acceptance. Often in today's age, we live in an age where there is a lot of information. So many patients have already Googled what they think they have, and they have their own fears. So it's important that the neurologist discusses with the patient the nature of the illness. The other thing is the acceptance that this is a degenerative problem. That means a strategic part of the brain's functional efficiency has changed.
Correct.
One has to embrace it and understand with faith and with trust that there are medications at every stage which can help deal with the symptoms. So the medications are drugs, those which stimulate the dopaminergic system. There are called direct and indirect dopamine stimulators. And a neurologist would prescribe them. When you consume them, the symptoms get better. Each of these drugs have a certain half-life. So the duration of the positive effect is limited to a few hours. So it requires sometimes frequent dosing. And with that is also the understanding that as time goes by and symptoms will worsen, just like when we age, many of our capabilities drop. And we often accept that, saying that I'm older, so it is okay. So in the same way, with passage of time in Parkinson's disease, severity will worsen. But the good thing is that at every stage, there is something that you can do.
Right.
And in many patients with advanced Parkinson's disease, there is a surgery.
Okay.
So the surgery is a complex intervention. It's called deep brain stimulation, or DBS, where a very skilled surgeon can implant electrodes in a very strategic part of a small few millimeter zone in the brain that has links to this nigrostriatal system. And it is connected to an external battery, and the battery produces repetitive electrical stimulation. So when you do this stimulation, symptoms improve.
Got it. But it's important to note that this is not a disease that can be cured. It's just one where the symptoms can be managed with medication and surgery, correct?
Most diseases, I think, on a philosophical plane, I think are treatable. The only curable ones are perhaps nutritional depletion and infections.
Correct.
Other than that, most other illnesses need to be dealt with. And some of them respond to medications and surgical interventions. Some also need, or most also need, lifestyle interventions.
And in fact, that brings me to Dr. Shetty. I think this is the part that you come in, that when a patient is diagnosed, right, by Dr. Desai, and they've had these treatments, but then there's a lot of depression and anxiety that follows. I read a statistic that as many as 50% of the patients, probably more, go through depression. How do you help them?
No, I think before depression, first this denial.
Correct.
Just transacting information about the illness is not enough. Because when there is denial, there's a bottle full of myths, a fountain full of emotions. ये मुझे कैसा हुआ? Why me? it is not possible. I've played lawn tennis. I still remember this man who's been playing lawn tennis for 30 years. His gait shortened. He could not play. He was diagnosed to be having Parkinsonism. He said, it cannot be me. And to transact an information about the illness so that he accepts, there's a lot of two-way dialogue that has to happen. He has to share all the thoughts which could be mythical and not true to the doctor, and the doctor should accept that, acknowledge that is a state of mind. A lot of feelings which come up are fear, anger, at times jealousy. My brother did not have it. My entire family does not have it. Why me? And also a lot of sadness. How will I show my face to my friends with whom I drink beer and play tennis? At the same time, what also happens is that you feel you are incapable of doing your own things. You are less capable of earning your money. I can't show my face in functions. So that shame becomes so strong.
Shame is a very big thing.
And if we are able to delicately, very sensitively listen to all that, slowly acceptance starts. And we also ask patients to seek the spiritual journey, to pray to God, not to find answers in science, so that acceptance becomes much stronger. As Joy would say, acceptance helps you to treat the illness much better, pick it up much earlier, without stoppage of medicines and without doctor shopping. But anxiety is also a very big factor, where you get palpitations, you suddenly don't feel good. There are enough studies to say that yoga and meditation helps you to calm down your sympathetic tone, calm down your anxiety, so that you are able to live your life moment to moment.
Correct.
That is so important. But then Parkinsonism is not so simple when it comes to psychiatry. It also means that somebody who has been depressed for a long time, under treatment, suddenly slows down. And that does not mean that it is an increase in the symptoms of depression. I know a woman who has been not talking for the last 8 months. First diagnosis was depression. Somebody told her that she needs to take advanced depression treatment. Though she was on antidepressants, and I gave her antidepressant also, she improved a little, but I found that she had early signs of Parkinsonism not related to the depression. And adding medications for Parkinsonism improved her depression, and she is able to live much, much better. But what happens is, in India, in a family, the father-in-law takes a decision of where one should go for the holidays. But person who takes the decision for health is somebody. Is the uncle, is the guy in United States of America, is the doctor in the family who's a cousin. It's important to get that decision maker into the frame of conversation so that it does not misguide the patient and he goes shopping for many doctors. What is also very important is some drugs for depression also work for Parkinsonism.
So that's a very unique thing. We talked about dopamine being important for movement, but we also know that dopamine is very important as a neurotransmitter in many neural networks that drive motivational behavior, the pursuit of pleasure, the pursuit of goals, and engaging behavior. So therefore, it's not surprising that if your dopamine reserve has dropped, one of the things it could take away is your motivated behavior.
It's called the happy chemical, right?
Yes. Yeah. And so when the motivated behavior drops, it appears to be like someone who is depressed and they need therapy for depression.
Right.
But Dr. Shetty just mentioned that they also have subtle forms of movement change which warrants understanding. So when we give dopamine agonists, it helps them feel better.
Right.
Besides the movement, their inner sense of well-being improves.
Right. So along with Parkinson's, you're treating depression and you can reduce the feelings of depression as well.
Improve too.
Not really. It is actually that I would give a drug for depression which also works for Parkinsonism. and he gives a drug for Parkinsonism, which also works
Okay. Okay, understood.
for resistant depression.
Understood.
And so there's a lot of overlap between the medications, not in terms of the illness. Some patients become depressed after they are diagnosed to be having Parkinsonism, not because of the psychological impact, because of the shift in the neurotransmitters in the brain. So they would need antidepressants along with Joyce medicine. But some patients, because of the medications of Parkinsonism, may lose sleep, may become high, may believe that they are the prime minister of the country, and that's the time when the psychiatrist and the neurologist should be speaking to each other always, wherein he will adjust his medication, I will adjust mine, so that a balance is kept.
So that is very important.
But the problem is, Namita, we have learnt in MBBS and MD that liaison neurology or liaison psychiatry is important, but unfortunately, doctors don't speak to each other.
Doesn't happen in real life, in practice.
A psychiatrist will prescribe his medication, neuro will prescribe his medication, and the guy will come with both the prescriptions and he says, please talk to each other. So it's important for a senior psychiatrist or a senior neurologist to pick up the phone and talk to any neurologist or any psychiatrist who's giving medication. That's one of the biggest flaws in the practice of medicine.
I think that is such an important point you raised, especially for a patient to understand that modulation in medication may be required, where that kind of conversations are required between the two
It's
specialists.
so important.
Yes. Last time in our Alzheimer's episode, when you had come, you had also spoken about the caregiver having depression and going through massive anxiety because there's just so much they have to do. Is that an issue in Parkinson's as well?
Absolutely. See, families are shrinking. You are staying in studio apartments. You may have 3 cars, but you are 4 of you all. And that wife or that husband who's supposed to take care of their spouse or their parents get completely exhausted because they are not understood by anybody. What is very important for the spouse or the caregiver to understand is there should be no guilt in having fun. So Indians generally feel that my father is on the bed, he is so suffering, I should not go and see a movie. We try and explain to them nowadays that if you take a break and have a blast, you will be able to take care of yourself and your parents much better.
Very true.
That is so difficult to really negotiate. So what I do, I call a family meeting with all the siblings. Whoever is available. Some siblings feel they're far away, they can give money for treatment. Some siblings feel that they can take the patient to the doctor, but the caregiver can be at home. We find a way by which the caregiver is given enough vacation, enough holidays, and the guilt removed that enjoying does not mean that you don't care for the person who has Parkinsonism. And that engagement, that transaction, that negotiation is one of the most toughest to make. Now you'll say, go to a psychologist. Psychologists are not easily available. Travel is so difficult. So the best thing is to do an online meeting with the family so that you gently, subtly, and in a nuanced manner see that the responsibilities are reasonably shared and it is not lopsided. And it's not very polarized. But Indian family members are different. Indian caregivers are different. They want to be the martyr and the sole caregiver of the patient.
Yeah.
And there we say, involve also your children.
Yeah.
I tell all caregivers, bring your family along with you as much, as often as you can. So the young grandson also is trained to hold his father-in-law to go to the loo. So having a multipolar care without shame, without guilt, and without wanting to be a martyr. Lastly, many family members feel, the caregivers, I should not trouble my growing son, he's appearing for JE. Or is doing something to do with education. What happens is, coming with your father or your mother or your grandfather or your mother, occasionally to the doctor, they share the burden, and it's so important. And what is also so important is when the caregiver dies, you have to pass the baton to somebody else. Please start early.
That's very important. But there must be support groups also. Are there support groups? Because every time you can't have a doctor available or a caregiver.
Madam, support groups have undergone a transformation. I ran a support group from 1998 till COVID. It was offline, and the family members would meet for mental illness, and the patients would meet, and we found it to be tremendously useful. Now, traveling inside the country anywhere is very difficult. So I would advocate to the families and the other doctors, please have a support group online once a month so that people can talk. And Joy will explain to you that there's a big support group.
There is, okay.
So there is a
That's
very
good to know.
large support group. In fact, there is more than one. So there is a Parkinson's disease and related disorders Foundation of India, which Society of India, which was started by one of my colleagues, Dr. Bhim Singhal, whom you know. And then the running of the foundation has become really gigantic across the country thanks to the members who are participating.
How many members would it have?
Oh, I don't know the number,
Thousands.
but they are very large numbers.
Society. So that's good.
And they have branches all over the country.
Okay.
And it's a very well managed support group. There is a Parkinson's Disease Foundation, which was started by one of my other colleagues, Dr. Bhatt. And that also has its own structure. So certainly there are support groups one can reach out to, and a lot of value can be gleaned from that. And it's again a journey.
Right.
And that journey is useful because many things can come out. If you do group activities, all the Parkinson's foundations globally also have annual days when they do a dance. And any form of dancing is one way of integrating movement in a fluid manner.
Correct.
So it includes cardio, it includes core exercise, it includes balancing. So it's really very good for patients with Parkinson's disease.
You know, a couple of statistics I want to run by you. One is longevity. It's a myth that patients die early. What do you have to say to that? And second is incidence. How many people per 1,000 have Parkinson's in our country?
So what we know overall, globally, I think it's 1 to 2 per 1,000.
Okay.
So it's not a very small number. It's a reasonable number.
Absolutely.
And if you really see what happens to the brain when it is struck down by this devastating illness, is that there are components of 2-3 things. There is a kind of energy failure. So all our neural networks are composed of a small organelle called the mitochondria. And these organelles can be considered as a energy provider, as its primary role. It's got many other roles, which we have understood now, but the primary role is that of an energy provider.
Right.
And these mitochondria fail in patients with Parkinson's disease. And then there is secondary change of cellular activity called inflammation, and that leads to this degenerative process. So many of the things that you do in your daily life can allay this process. So exercise, dancing or otherwise is good for your mitochondria. Maybe a couple of cups of coffee in a day have been shown to be pro-mitochondria.
Spoke about sleep.
Sleep is the biggest mitochondrial rejuvenator. So investing in sleep as a complete restorer can also help patients with Parkinson's disease cope.
Right. Sorry, longevity is a point also we wanted to
And,
discuss. Is it a controversial question?
It's a very controversial question because if we really know, longevity is a composite of many things. So if a person with Parkinson's disease has other comorbid illnesses like hypertension, diabetes, and coronary artery disease, then the additional burden of Parkinson's disease can be a detractor from whatever is the anticipated longevity.
Right.
But I wouldn't want to instill any fear in people. I think nobody really knows how long they're going to live, even when we are seemingly normal.
Absolutely.
So I would rather embrace the notion that, okay, here's something that I have, here's an expert that's educating me about it. And if I can deal with this on a day-to-day basis, we will take the future as it comes.
You know, some people where it's detected when they're young. So it's not just an old person's disease.
Yes.
So is that relatively a very small percentage of cases? Or that's
Yes.
significant as well?
Yes. So we talked about this mitochondrial failure, but there are also genes that make this network susceptible.
Correct.
So there are numerous genes, and we are learning that there are many more new genes which we did not know a few years ago. So some of these genes that make an individual susceptible, they are associated with a younger onset. So there is a PARK7 gene called the DJ gene,
Right.
and there is a GBA gene, which is called the glucose cerebrosidase gene, and they are associated with younger onset Parkinson's at times.
Related to this, I've heard it can be so debilitating that you lose your ability to speak. Now, when it's something that extreme, which happens to a lot of people with Parkinson's, how can you tell them to have a normal life?
I'll tell you. I'm not saying normal life. I'm saying
Or to even stay
lighthearted.
positive.
Yeah. So even when somebody is in coma or has lost his ability to sleep, the patients who had FTD, the caregiver, we ask all the grandchildren to go and tell the patient what they did across time. We ask all the children or whoever it is to sit down and say what are the good things and bad things that happen throughout the day without expecting an answer. Remember, in Parkinsonism or dementia, the entire brain is not dysfunctional. There are parts of brain which registers. And I've seen people coming back and saying that my grandfather smiled for some time. And at the same time, all neurological illnesses, when the carers are empathic, smiling, and in turns going and speaking to them, the improvement is much better, and the quality of life, which I would say is much better. I had a man who had incontinence along with Parkinsonism, dementia also, sitting in front of the window, watching the grass, watching the mountains from his house, helped him to feel much better. I have a woman who has Parkinsonism, and she said, I will not give up. I know my hands tremble, but I still will continue my crochet as slowly as I can, and that gives me meaning in life. So what is important is every patient has some wisdom, every carer has wisdom. Instead of we giving gyan all the time, most of it is Western. Let us also understand what are the mood lifters and the mood shifters they have used in the past, which they can use now in smaller proportions.
That's a
So,
great
what
insight.
Dr. Shetty mentioned, the value of finding awe in simple things. It is actually neuroregenerative. And we didn't think about this, but current neuropsychology and science promotes finding awe in simple things for brain health.
Absolutely.
So we actually have awe walks for patients with dementia.
Or walks.
Yes.
That's a new term.
Yeah, so you go for a walk with the patient where you can admire the sunshine, the sunset, the leaves in the tree, a dewdrop that has come up, the prettiness of a flower, the outside
The
of a
Pancha
mountain.
Mahabhut. We encourage our patients to have a longer bath, be childlike with water. That really is neurogenerative. At the same time, playing with clay if they can, looking up at the sky, feeling the air, and looking at the rising sun, the setting sun. It's there in our scriptures. Americans gave it a new name. So I tell all adults, if they can play with water, if they can be childlike and not be upset because their spouse, husband or wife, knocks at the door of the bathroom, they'll be happier and better human beings. It's applicable to all illnesses.
My God, we covered Parkinson's from every angle. We looked at the science, the causes, the symptoms, the diagnosis, the treatment. We looked at the support groups, the depression, the psychiatric, the collaborative approach that's needed between specialties. So I think it's been brilliant because we've given a complete holistic view of this condition. Any parting words in terms of anything we might have missed out that you'd like to give as an awareness for all our listeners?
I think embrace, accept, and find value in engagement. If we can do these three things in the presence of illness, embrace it, accept it, and find value in new engagements, then coping with this is not such a big challenge.
Thank you. So beautifully said. What about you, Dr. Shetty?
Slow down and let the natural orchestra of the body play its music and not shore. Sur and not shore. Do not defy the natural habits of the body, and the body is the biggest pharmaceutical company both for physical illnesses and stress and mental illness. Let it work at its own pace.
That is beautiful. I mean, when we talk about walks, enjoying longer baths, look at the sunrise, look at the sunset, a lot of times people say, "Arey, kiske paas time hai? All hocus pocus, ye kya baat kar rahe ho? It's a rat race to be the first and the fastest." But when the most reputed neurologists and psychiatrists of the country say the same thing, it's time to wake up, time to listen, time to slow down, time to take that longer bath, time
Smell
to
the
make those
coffee.
emotional connects, smell the coffee. Because all of that impacts your brain, and ultimately all these conditions that we talk about are something that we can slow down, manage symptoms with good lifestyle changes early on. But if you do have Parkinson's, I think today you have invested in yourself, invested in education such that you can help others, and by knowing all these basics, I hope you become a more positive, productive, healthier person to lead a better life. Thank you so much.
Thank you.
Thank you.